Well, good evening. Thank you all for joining us. This is the uh, webinar on new technology for occipital cervical fixation, presented to you by the Cervical Spine Research Society. I'm very pleased to co-moderate this with Dr. John Heller. A couple reminders. We do have the 52nd annual meeting of the CSRS coming up this December in Chicago. Abstracts are currently being accepted for another few weeks until April 24th. So we encourage everyone, if you have any research to submit, we would love to see it at the 52nd annual meeting. We also want to remind people that the Clinical Spine Surgery Journal is the official journal of the Cervical Spine Research Society. We'd encourage you to submit any papers focused on cervical spine to the cervical spine surgery for possible inclusion in the upcoming issues. We're also with the CSRS becoming involved with social media, so we encourage you to follow us on the various formats, whether it's in LinkedIn, Instagram, X, or Facebook, and those are all the various identifications of the CSRS on those societies. So please give us a follow so we can keep you up to date on any other upcoming events with CSRS. And then, as I mentioned, CSRS has a YouTube channel. This is a repository of presentations put on either at CSRS, the instructional course, or webinars like this. There's a growing amount of information there, so please give it a look and subscribe to the CSRS YouTube channel. So tonight, this is just our agenda for the evening. So Dr. Heller and I will lead off. Then we'll have Dr. Heller will do a review on anatomy. I will talk about how I do it for occipital cervical using both freehand and fluoro-assisted. And then we're really pleased to have Ilyas Aleem from University of Michigan to talk about how he does it with navigation assistance. And we're especially proud to have Dr. Nick Theodore from Johns Hopkins, one of the fathers of robotic spine surgery, give us his take on how he does it with using robot assistance. And then we'll finish up with some case presentations. We have one from Dr. Heller, and if time permits, I have one as well. And we'll all the panelists will be there for a live discussion. I'll take the next part. My name's Neill Wright. I'm one of the neurosurgeons at the Neurosurgery of St. Louis. I have a cervical-only practice now, and I previously was the Herbert Lowry Professor of Neurosurgery at Washington University. I do have some disclosures which are relevant. I did develop several posterior cervical systems, some of which you'll see during this talk. However, I don't currently receive royalties for those now. And all the devices seen in this talk are approved for use by the FDA for spinal fixation. So along the course of this webinar, we're going to hear some of the advances in upper cervical fixation, such as navigation or with robotics. But I wanted to start off by talking about how we used to do these, or how I currently still do these surgeries with the assistance of fluoroscopy and with knowledge of the anatomy. So depending on what we're looking at in the occipital cervical spine, we have different options for fixation, whether it's in the occiput or C1, C2, or the subaxial spine. I want to show you how I set my patients up. This is a occipital cervical fixation case I did a few weeks ago. You can see I have them on an open table. I have them in a Mayfield. Now, other people would use Gardner-Wells with biplanar traction. I tend to use Gardner-Wells because I like the control that gives me the head position. You can see the fluoroscope in position there, and they'll be there for the remainder of the case. I do use a a head holder from Zuho, the Levo system. It's a pneumatic system to help position the head, allows me then to put traction onto the head to help reduce basilar invagination. It's very helpful for these types of cases. So starting with the occiput, my go-to is the occipital keel plate. There are some historical other things we could try, but since the advent of these keel plates, this is really my go-to unless they've had a previous suboccipital decompression. Most of my work is done on the preoperative imaging. I'm looking at the midline sagittal view. I want to see the thickest part of the keel, and I'm going to measure the various points where I'm going to put it in. I do want to identify where the Imnion is for two reasons. One, that's a good anatomic landmark, but more importantly, that's the torcula lies the other side of that. For the non-neurosurgeons in the audience, the torcula is the confluence of the sagittal sinus and the transverse sinuses. It's a very vascular structure, and you want to avoid it intraoperatively. So you'll see here on this video, I have exposure of the occiput. I have the Imnion up here. I can feel that notch below it's where the top end of my occipital plate will go. There's several different brands of occipital plate we could use. They all have some variation of midline holes. Some of them have holes on the side, which I tend not to use because I find the occiput gets very thin, 8 to 10 millimeters away from the keel. So I'm lining this up with the keel just underneath the ilium. I've measured preoperatively on my preoperative CT scan the depth of these screws. I will put these screws in under power. I find you're putting a lot of force against the occiput. If you do it with a hand drill, that you end up putting a lot of force against the head, potentially can pull them out of their pins. So I tend to do these under power. I drill it with a drill guide because I want to make sure I don't plunge. You'll see it's good. It gets hard through the outer cortical bone. It gets a little bit softer, and then it will plunge again as it goes through the inner cortical bone. If you get some venous bleeding, that's okay. If you get cerebral spinal fluid, that's okay. You do want to tap the length of that screw. I do that also through the drill guide. I don't want to plunge into the space there. So I will drill and tap that whole length and then put the screw in. It's important to tap the whole length. This is typically hard cortical bone. You're putting a cortical screw in there. If you don't tap it, the screw could well strip. If you get cerebral spinal fluid, it's typically not a big deal. You can tamp on that by putting the screw in place. Typically, we'll put the screws under hand power, not power. I don't want to strip them. Typically, leave them a little bit loose till the very end. I'll tie them all together. And then you'll see the final construct here with all 3 screws in place. For C1, I typically will put a C1 lateral mass screw in. There's a lot of anatomy to recognize around it. We have the spinal cord. We have the C2 root coming underneath the screw. We have the vertebral artery coming laterally and then rostrally. There are a lot of anomalies of anatomy in this location. You need to study your preoperative films. There can be a dehiscence of that sulcus arteriosus, such that the vertebral artery actually enters into the space where you're normally putting your C1 screw. You have to be able to recognize that. And then this trajectory of screws is typically 10 degrees lateral to medial to avoid the foramen transversarium there. Again, I do my planning on my preoperative imaging. I'm doing my parasagittal CTs, and I'm looking at the various axial CTs that relate to that. I want to find the axial slice that shows me the whole lateral mass just below the arch of C1. I want to measure that depth for drilling. I don't want to be bicortical here because you have both the pharynx, sometimes the carotid arteries here. So I want to measure this. That's anywhere typically 10, 12, 14 millimeters deep. I also want to measure the total length of where my screw head will be, and that's typically a 28 or 30 millimeter length screw. You can do a little notch in that bone if you understand where the vertebral artery is. That sometimes makes it a little bit easier to see that posterior lateral mass. And again, you want to aim 10 degrees lateral to medial to avoid the foramen transversarium there. So just an illustration of that. I always will have a piece of metal, in this case a fenestrated sucker, between where I'm working and the vertebral artery. So I'll put the fenestrated sucker in, pull it laterally to protect the vert. My assistant is pulling down the C2 root. I've already palpated the posterior aspect of the lateral mass, and I'm making a little hole with a high-speed drill. The reason I do that is it's not typically a flat surface of the lateral mass. Usually it has a slope to it. And by putting this little matchstick head exactly where I want it, then when I put my hand drill in, it keeps it in that position and it doesn't skive medially or laterally. Then I'll take a lateral fluoroscopic picture here, and I want to aim towards the anterior arch of C1. You'll see that here in just a minute. So I'm aiming towards the anterior arch of C1, again going about 10 degrees lateral to medial. Once I have that trajectory, I'll drill with the length that I've decided on that preoperative imaging, that 12, 14 millimeters. Check my fluoro again to make sure I'm in that same trajectory. Feel that with a ball tip probe, tap, and then put my screw in. You can see the final construct there. For the several other options for C1, you can ligate the C2 root. I tend to do that more frequently now. It gives you better access into the 1-2 facet joint, especially if you want to decorticate the facet joint or put any bone spacers in there. It also does tend to minimize your blood loss. For C2, there's several options. There's C2 pedicle screws here. I'll mention these briefly. I typically don't do these with navigation. I typically will do this with, I don't do this with fluoroscopy. I do my C2 with navigation. But you are trying to palpate the medial border of the pedicle. The entry point is typically then in the cranial and medial quadrant of the isthmus surface of C2, and you're aiming the screw about 30 to 40 degrees rostrally and about 30 degrees lateral to medially. But again, I would strongly recommend using navigation for these because there are other options which you can do safer just with fluoroscopy alone. And that's the C2 par screw. This is very easy to put in with fluoroscopy. The entry point is a little bit lower than the pedicle screws. I tend to make my entry points a little bit more medial because I want to line them up with the lateral mass screws. But then you're feeling the medial border of the pars, and you want to hug that medial border. The screws are typically about 30 to 40 degrees lateral to medial, and typically 40 to 50 degrees superiorly. Here's just an illustration of that. You see my C3 lateral mass screw in. I've made a little entry hole, mainly to line up the screws, make it easier for rod contouring. That's where my screw will start. And now I need to feel the medial border of that C2 pars for my trajectory. I want to aim as close as I can to the medial border, just lateral to that medial border of the pars. So now once I felt it, I put my drill guide in place. Typically do this under power. I'll bring my pen feel forward with my other hand to feel the medial border of that pars, and I'm aiming just lateral to that. I'll do a fluoroscopic picture there, and then subsequently the screw inserted. You could, there's what the final construct looks like with C2 pars on a CT. Or you could put laminar screws in. Laminar screws are probably the easiest to put in. You don't need any type of navigation or fluoroscopy here if you're not familiar with them. These are crossing C2 screws in the posterior elements. Another way of looking at it on a sawbones or from the rear from a sawbones, you recognize that you have to plan for the screws to cross. So one's more rostral, one's more caudal. You can see sketches there of how they're put in and how they look like on the final construct. So this, forgive the graininess of this. This is when I initially introduced C2 laminar screws at CSRS in 2003. This is the video I showed then. So you're making a high-speed drill right at the junction of primes process on lamina, and you're simply sighting down that lamina. You're looking down the slope of that lamina, and you're drilling that. I typically do this with power now because you can see how much I rotate the posterior elements. And it's typically about a 30 millimeter length screw, 3.5 millimeter wide, and forgive my dogs in the background. Typically then have to palpate with a ball tip probe to make sure you're palpating with that ball tip probe to make sure you haven't violated a canal, and then you're putting the screw in. As in 3.5 by 28 to 32 millimeter length screw, it's very robust fixation of C2, and then you're gonna do another one the opposite direction. Below C2, there's options of lateral mass screws. These are very easy to put in. I don't typically use even fluoroscopy for this, just using landmarks. If you wanted to put pedicle screws in between C3 and C6, I would recommend doing that with navigation and not just with fluoroscopy alone. So there's some advantages of doing it this old-fashioned way with just fluoroscopy and anatomic landmarks. You're reliant on your visual and tactile anatomy, which means there's no concern of a registration error or segmental motion from one segment to another. If one part of the spine is mobile relative to where you have your reference arc, it doesn't matter because you're directly visualizing the anatomy each level. There's also minimal intraoperative radiation to the patient. There's no C-arm, so no O-arm spin or 3D fluoro spin to register your navigation or robot. However, there's several disadvantages. There is some low-level radiation to the surgeon and staff from the fluoroscope. If I'm doing a occipital cervical case, there's typically a handful of spot images, 1 or 2 at C1, 1 or 2 at C2, a couple shots maybe at C7 or T1 for pedicle screws. So all told, the entire case, it's usually less than 10 seconds of fluoroscopy, but you're right there in the field, so you are getting some exposure. I think most importantly, this does rely on you identifying anomalies on your preoperative imaging. Since you're not doing an O-arm spin or fluoro spin, nothing else is going to identify that anatomy for you, that aberrant anatomy, if you haven't identified it on your preoperative imaging. This is also challenging with distorted anatomy. It is riskier for C2 pedicle screws or subaxial pedicle screws, and there's also intraoperative discomfort from wearing a lead apron in the whole case. Thank you very much. I'm looking forward to hearing the next talks on navigation and robotics. Thank you. Well, I thought this was an amazing webinar. I really appreciate the working with John, and I really appreciate the input from Dr. Theodore from Johns Hopkins and Dr. Aleem from University of Michigan, looking at these new technologies. I think they are bringing extra tools to the field and making our surgeries better. So, John, unless you have anything different, I'd just like to thank everyone for participation and a wonderful webinar.
Yeah, thanks. It's like we had a good crowd, and hopefully everybody enjoyed it.
Yeah, thank you for putting together, Neill.
Maria, thank you for cobbling all this together. Close it out. Have a good night, everyone.
Thanks.
Yeah, thank you, everybody.